What is breech? Babies lying bottom first or feet first in the uterus, womb, instead of in the usual head first position are called breech babies. Breech is very common in early pregnancy, and by 36 to 37 weeks of pregnancy, most babies turn naturally into the head first position. Towards the end of pregnancy, only 3 to 4 in every 100, 3 to 4%, babies are in the breech position. Why is my baby breech? It may just be a matter of chance that your baby has not turned into the head first position. However, there are certain factors that make it more difficult for your baby to turn during pregnancy and therefore more likely to stay in the breech position. These include: if this is your first pregnancy, if your placenta is in a low-lying position, also known as placenta previa, if you have too much or too little fluid, amniotic fluid, around your baby, if you are having more than one baby. Very rarely, breech may be a sign of a problem with the baby. If this is the case, such problems may be picked up during the scan you are offered at around 20 weeks of pregnancy. What if my baby is breech towards the end of my pregnancy? If your baby is breech at 36 weeks of pregnancy, your healthcare professional will discuss the following options with you. Trying to turn your baby in the uterus into the head first position by external cephalic version, ECV. Planned cesarean section. Planned vaginal breech birth. External cephalic version, ECV, turning a breech baby in the uterus. What does ECV involve? ECV involves applying gentle but firm pressure on your abdomen to help your baby turn in the uterus to lie head first. Relaxing the muscle of your uterus with medication has been shown to improve the chances of turning your baby. This medication is given by injection before the ECV and is safe for both you and your baby. It may make you feel flushed and you may become aware of your heart beating faster than usual, but this will only be for a short time. Before the ECV, you will have an ultrasound scan to confirm your baby is breech, and your pulse and blood pressure will be checked. After the ECV, the ultrasound scan will be repeated to see whether your baby has turned. Your baby's heart rate will also be monitored before and after the procedure. You will be advised to contact the hospital if you have any bleeding, abdominal pain, contractions or reduced fetal movements after ECV. ECV is usually performed after 36 or 37 weeks of pregnancy. However, it can be performed right up until the early stages of labor. You do not need to make any preparations for your ECV. ECV can be uncomfortable and occasionally painful, but your healthcare professional will stop if you are experiencing pain, and the procedure will only last for a few minutes. If your healthcare professional is unsuccessful at their first attempt in turning your baby, then, with your consent, they may try again on another day. If your blood type is rhesus D negative, you will be advised to have an anti-D injection after the ECV and to have a blood test. See the NICE patient information routine antenatal anti-D prophylaxis for women who are rhesus D negative, which is available at www.nice.org.uk/guidance/tar156/information for public. Why turn my baby head first? If your ECV is successful and your baby is turned into the head first position, you are more likely to have a vaginal birth. Successful ECV lowers your chances of requiring a cesarean section and its associated risks. Is ECV safe for me and my baby? ECV is generally safe with a very low complication rate. Overall, there does not appear to be an increased risk to your baby from having ECV. After ECV has been performed, you will normally be able to go home on the same day. When you do go into labor, your chances of needing an emergency cesarean section, forceps or vacuum, suction cup, birth is slightly higher than if your baby had always been in a head-down position. Immediately after ECV, there is a 1 in 200 chance of you needing an emergency cesarean section because of bleeding from the placenta and/or changes in your baby's heartbeat. ECV should be carried out by a doctor or a midwife trained in ECV. It should be carried out in a hospital where you can have an emergency cesarean section if needed. ECV can be carried out on most women, even if they have had one cesarean section before. ECV should not be carried out if you need a cesarean section for other reasons, such as placenta previa, placenta accreta and vasa previa. You have had recent vaginal bleeding. Your baby's heart rate tracing, also known as CTG, is abnormal. Your waters have broken. You are pregnant with more than one baby. Add pause 1. Is ECV always successful? ECV is successful for about 50% of women. It is more likely to work if you have had a vaginal birth before. Your healthcare team should give you information about the chances of your baby turning based on their assessment of your pregnancy.
If your baby does not turn, then your healthcare professional will discuss your options for birth. It is possible to have another attempt at ECV on a different day. If ECV is successful, there is still a small chance that your baby will turn back to the breech position. However, this happens to less than 5 in 105% women who have had a successful ECV. Is there anything else I can do to help my baby turn? There is no scientific evidence that lying down or sitting in a particular position can help your baby to turn. There is some evidence that the use of moxibustion, burning a Chinese herb called mugwort, at 33 to 35 weeks of pregnancy may help your baby to turn into the head-first position, possibly by encouraging your baby's movements. This should be performed under the direction of a registered healthcare practitioner. What are my options for birth if my baby remains breech? Depending on your situation, your choices are: planned cesarean section, planned vaginal breech birth. There are benefits and risks associated with both cesarean section and vaginal breech birth, and these should be discussed with you so that you can choose what is best for you and your baby. Cesarean section. If your baby remains breech towards the end of pregnancy, you should be given the option of a cesarean section. Research has shown that a planned cesarean section is safer for your baby than a vaginal breech birth. The cesarean section carries slightly more risk for you than vaginal birth. Cesarean section can increase your chances of problems in future pregnancies. These may include placental problems, difficulty with repeat cesarean section surgery, and a small increase in stillbirth in subsequent pregnancies. If you choose to have a cesarean section, but then go into labor before your planned operation, your healthcare professional will examine you to assess whether it is safe to go ahead. If the baby is close to being born, it may be safer for you to have a vaginal breech birth. Vaginal breech birth. After discussion with your healthcare professional about you and your baby's suitability for a breech delivery, you may choose to have a vaginal breech birth. If you choose this option, you will need to be cared for by a team trained in helping women to have breech babies vaginally. You should plan a hospital birth where you can have an emergency cesarean section if needed, as 4 in 10, 40%, women planning a vaginal breech birth do need a cesarean section. Induction of labor is not usually recommended. While a successful vaginal birth carries the least risks for you, it carries a small increased risk of your baby dying around the time of delivery. A vaginal breech birth may also cause serious short-term complications for your baby. However, these complications do not seem to have any long-term effects on your baby. Your individual risks should be discussed with you by your healthcare team. Before choosing a vaginal breech birth, it is advised that you and your baby are assessed by your healthcare professional. They may advise against a vaginal birth if your baby is a footling breech, one or both of the baby's feet are below its bottom. Your baby is larger or smaller than average. Your healthcare team will discuss this with you. Your baby is in a certain position, for example, if its neck is very tilted back, hyperextended. You have a low-lying placenta. You have preeclampsia or any other pregnancy problems. What can I expect in labor with a breech baby? With a breech baby, you have the same choices for pain relief as with a baby who is in the head-first position. If you choose to have an epidural, there is an increased chance of a cesarean section. However, whatever you choose, a calm atmosphere with continuous support should be provided. If you have a vaginal breech birth, your baby's heart rate will usually be monitored continuously, as this has been shown to improve your baby's chance of a good outcome. In some circumstances, for example, if there are concerns about your baby's heart rate, or if your labor is not progressing, you may need an emergency cesarean section during labor. A pediatrician, a doctor who specializes in the care of babies, children and teenagers, will attend the birth to check your baby is doing well. What if I go into labor early? If you go into labor before 37 weeks of pregnancy, the balance of the benefits and risks of having a cesarean section or vaginal birth changes and will be discussed with you. What if I am having more than one baby and one of them is breech? If you are having twins and the first baby is breech, your healthcare professional will usually recommend a planned cesarean section. If, however, the first baby is head first, the position of the second baby is less important. This is because, after the birth of the first baby, the second baby has lots more room to move. It may turn naturally into a head-first position, or a doctor may be able to help the baby to turn.